Good evening, ladies and gentlemen, and thank you so much for joining us for our Eating Disorder Hope webinar presentation with the Acute Center for Eating Disorders, featuring our special guests this evening, Dr. Margherita Mascolo and Dr. Gillian Taylor Lashen, who are special presenters for our topic on eating disorders in the emergency room, treating the physical and emotional crisis. We're so delighted to have them both, and they have a wonderful presentation planned. Before we get started, I'd just like to bring your attention to a couple of housekeeping things. During the presentation, you will have the opportunity to submit any questions to the presenters at any point during the presentation. You can submit your questions through the question pane of your control panel. You can just go ahead and type them in there. We will be collecting them, and I will be reading them to our presenters at the end of their presentation when we transition to our Q&A portion. Also, you will be awarded 1 CE unit for watching this presentation and completing our evaluation form. At the end of their presentation, I will be making available the evaluation form, which will be through a hyperlink, and that link will be put in the chat box, which is also in the control panel that you have available for you. So without further ado, I would like now to transition this over to Dr. Mascolo.
Thank you, Jackie. Thanks for having us here today. I'm the medical director of the Acute Center for Eating Disorders here in Denver. We take care of the country's sickest anorexics and medically stabilize them and then send them to treatment facilities all over the country to continue on their recovery journey. So we'll talk about sort of the emergency room treatment in these patients because unfortunately there's so little medical knowledge known about them, and really we must get the word out, and you guys as eating disorder professionals are sort of on the front line of this. So we'll talk about how eating disorders continue to remain undiagnosed in this country, discuss some of the common presenting complaints and physical sign abnormalities and symptoms that might clue somebody in that somebody has an eating disorder, touch briefly on the pathophysiology and treatment of especially electrolyte imbalances, which are commonly seen in the emergency room, and really throughout the presentation talk about what the criteria for hospitalization are. When do these patients need a higher level of care? And so that's sort of our roadmap of what we'll go through today. So some of the statistics, I'm a physician, so we love numbers and stats. The rate of development of new cases of eating disorders has actually been increasing since 1950. Especially the incidence of anorexia in patients in the ages of 15 to 19. That's been increasing every single decade since the 1930s. So although it's still not really as mainstream, I mean, we, ever since Karen Carpenter, there hasn't been a lot of mainstream media about the severity of these disorders. We are seeing more and more of them. The incidence of bulimia in the 10 to 39-year-olds has tripled since in 5 years, from 88 to 1993. We unfortunately don't have any more recent statistics. However, in Western industrialized countries, the prevalence of eating disorders remains about 0.9% of the female population and 0.1% of the male population. Why is that? I mean, the media has such a huge impact on our lives. We're constantly on Facebook and Twitter and all kinds of social media. And we are exposed to about 3,000 advertisements daily. And a lot of these are purposefully designed to make women unhappy with their bodies. Because of this, about 69% of American schoolgirls that read magazines think that pictures influence their ideal of body and their ideal of their shape. About half of these kids say that pictures make them want to lose weight. And it's everywhere that we see. I mean, this is what is in our media, and this is what our patients are literally killing themselves to achieve, something that is very unrealistic and, quite honestly, very unhealthy. What is the problem? Over 80% of 10-year-olds are afraid of being fat. I mean, I don't know what you guys were doing when you were 10 years old, but that certainly wasn't a concern of mine. And certainly, I didn't know a whole lot about cancer. These kids are more afraid of fat than cancer, and as a medical provider, that's horrifying. Almost half of kids 9 to 11 years old are sometimes or very often on diets. And I mean, we have an obesity problem in this country, but it's a large spectrum of eating disorders ranging from obesity to anorexia, which is what we take care of. And about half of teenage girls and a third of teenage boys use unhealthy weight control behaviors such as skipping meals or fasting or smoking cigarettes or vomiting and taking laxatives as a means to control their weight. And I mean, smoking cigarettes has lifelong impacts on our health, and it really sets them up for a lifetime of medical issues and illnesses. I was horrified when I was doing research for this talk, and I sort of pulled up pictures of what American beauty pageants were like. The top picture is actually the very first pageant. The BMI of Miss America winners has decreased from 22 in the 1920s to 16.9 in the 2000s. So our standard and our ideals of beauty has completely changed. And even though the average American woman is 5'4" and weighs 165 pounds, the average Miss America is 5'7" and weighs 121 pounds. So again, unrealistic ideals and expectations that we're setting for our young men and women. 98% of American women don't look like fashion models, although they certainly try, and if they can't succeed, it makes them feel really guilty. There's about 20 million women and 10 million men that suffer from an eating disorder in the U.S., and that eating disorder is ranging from anorexia to obesity. However, anorexia remains the psychiatric disorder with the highest mortality. It carries a mortality risk of 5.1 deaths per 1,000 person years. It's very high, and these are deaths in very young patients. 20% of these deaths are occur because of suicide, and about greater than 50% because of medical complications. However, the sad part is that half cases of anorexia and about a third of the cases of bulimia are never even detected by the healthcare system. We are not diagnosing these patients. And why is that? I mean, are they not accessing medical care? Quite the contrary, and I'm going to quote a few studies. One of them looked at adolescents with eating disorders, and up to about 90% of them reported some contact with service providers, whether they were mental health providers or primary care physicians, school physicians, or school nurses. So they had contact with someone in the healthcare industry. Only up to about 28% had specifically talked with a professional about their eating disorder. Why? Well, in part, there's a lot of denial and shame associated with an eating disorder, but also because they stated that the physician or the professional didn't ask them any questions, didn't prompt any questions about an eating disorder, and so they failed to mention it. Another study of 150 women that presented for routine gynecological exams showed that ones that had a history of vomiting, starving, or laxative abuse, this isn't even a diagnosis of an eating disorder. These are just asking about behaviors. Well, those patients that engage in those behaviors actually use the healthcare system a lot more in terms of phone calls, in terms of specialty referrals, both in the subsequent 12 months of their initial visit, compared to women that didn't have a history of these behaviors. And lastly, there was a study in a large health maintenance organization here in the U.S. of patients specifically diagnosed with eating disorders. About 50% of ED cases were first diagnosed during a primary care visit. 50%. So we're still missing 50% of these patients. They did see, however, just like the prior study, that health service use was significantly elevated in all service sectors in the patients with eating disorders, both in the 12 months leading up to and in the 12 months following their index visit. So these patients are using the healthcare system. Why are we not diagnosing them? These are missed opportunities for treatment and for diagnosis and for intervention. And we know that older age at first presentation, greater than 20 years, as well as lowest lifetime BMI ever, are really significant prognostic indicators of mortality. So we have to do a better job of catching these patients early before their disease has gone on too long. Recognition really is key for them. So how do we go about that? What do we need to do? Well, number one, education. This was a really sad study done in residency programs in the U.S. 637 residency programs were surveyed. Of those, 514 programs had absolutely no rotation. The ones that did, on average, had a 1-month duration of rotation on eating disorders. Very few of them actually had no formal teaching. And why was this the case? Because there were very few experts available, and because we have no guidelines. We still don't know what, there's not a lot of evidence to the care of these patients, so we don't know how to treat them. The other sad component of this is that compared to other psychiatric diseases, things like autism and schizophrenia, eating disorders get very little research funds. So for a disease that affects 30 million individuals, the amount of funding that the government gives is very little. So it leaves little opportunity for research and advancement in the field. Despite all this, how do patients do? Well, about 50% have full recovery, 30% partially recover, which means they have a waxing and waning course. They readmit frequently to hospitals and to treatment facilities. And sadly, about 20% of patients never recover from their illness. The mean duration is about 7 years, and there was actually a study that came out within the last year quoting that recovery is possible even about 20 years out. So we should not give up on these patients and should continue to treat them aggressively. Well, let's switch gears. What are the medical complications? So these are the complications of the restricting kind of anorexia, and these are the complications of binge purge and bulimia. And they are, I mean, an internist's dream because they affect every single organ system. In the interest of time, we unfortunately can't go through this, but I'd like to highlight sort of what do these patients present with in the emergency room. Is there anything we can teach our emergency room colleagues in how to manage these patients? And we'll walk through a case together. So MK was one of our patients. She's a 23-year-old female with really no past medical history who came into the emergency room complaining of dizziness, palpitations, chest pain, and abdominal pain. Looking through her record, you realize that this is her 4th time in the emergency room in the past month, and every single time she was hypokalemic or had a low potassium. She tells you she's fine, she wants to leave because every time she comes to the emergency room and she complains of these symptoms, she gets loss of IV fluids and ends up being very swollen the next day when she's at home, which of course makes her, for someone who has fear of gaining weight and body dysmorphia, it makes her really sort of concerned and worried and scared. This time she said, well, her potassium is probably low because she had the stomach flu, and that's probably why she doesn't feel well. She tells you no other symptoms or behaviors. She hasn't fainted, she hasn't had seizures, and really is in a hurry to go home and get back to school. So what are some of the common complaints that of patients that have an underlying eating disorder? Sadly, there's no studies evaluating presenting symptoms of patients with anorexia. So how do they present with the ER? We don't have any studies validating their symptoms. We know that they show up to primary care physicians' offices with very vague complaints that are difficult to attribute to one particular illness. So they complain of dizziness or fatigue and palpitations, chest pain, syncope or fainting or near fainting, seizures, abdominal pain, low back pain, depression, anxiety. It's really difficult to sort of put these under one big umbrella. We did a little bit of a better job with bulimics. So bulimics have been studied a little bit more, and these are some of the most common presenting complaints: weakness, feeling bloated, and edema or swelling. And although we studied this, these are still very nonspecific complaints, so it's difficult to really pin them down to one particular diagnosis, especially if we don't know the questions to ask. So on physical exam, MK has a low core temperature of 35.6 degrees Celsius, a low blood pressure of 89/54, and a low heart rate of 49. there's no height or weight recorded in the emergency room, so you don't really notice that she's at a low weight. She appears cachectic. She has bitemporal wasting, and we'll go through some pictures to see what that looks like. She has dry skin that's cracked, and you notice some scabs on the back of her right hand. Her extremities feel a little cool. She has a slow heart rate, but it's regular. Her lungs sound good. Her abdomen is scaphoid, so it's small, and her bowel sounds are a little slow, and she has no lower extremity swelling or edema. You ask the nurses to please get a height and weight so you can sort of figure out what's going on with her. And her height is 5'5". She weighs 85 pounds, which places her at 68% of ideal body weight, or a BMI of 14.1. And so, you know, some red flags start coming to mind. You go back to her chart and you see that she's lost 10 pounds in the past month. So what do we do with these vital signs? What are the vital sign abnormalities of these patients? Well, these are all adaptations the body puts in place in order to consume as few calories as possible, given the few calories that are ingested. So number one, hypothermia, or a low core temperature. Commonly, these patients have a temperature of less than 96.8 Fahrenheit or 36 degrees Celsius. Up to about 20% of patients that show up in the emergency department, in the outpatient setting have this. Hypotension, or a low blood pressure, less than 90 systolic, less than 50 diastolic. Another 15 to 20% of patients with eating disorders have these vital signs as an outpatient, and they are completely asymptomatic. This is, again, when the weight is low, the blood pressure is going to drop. Bradycardia, or a low heart rate of less than 60 beats per minute. About 43% of patients with eating disorders have this. This is so sort of the norm that whenever a patient at a low body weight has a quote-unquote normal heart rate that's between 60 and 100, we need to start thinking about something abnormal going on, like an infection or an inflammation or some other stressor on the body. Just like they have bradycardia at rest, they have what's called exertional tachycardia. So their heart rate goes from sort of 30 when they're sitting to 180 when they do things like brush their teeth. And they'll tell you that the low heart rate is because they exercise 10 miles a day, they run 10 miles a day. And the difference is that their heart is not an athletic heart. Their heart is a deconditioned, weak heart. It's lost muscle mass, and so it has to beat faster to do even trivial activities like brushing your teeth. And it's something that we can use to reality check our patients. What does temporal wasting look like? This is a picture of a patient with temporal wasting, and you can see, I'm going to use the pointer, that the temporal bone is really, there's really no muscle here by the temporal bone, and so it results on this bone sticking essentially out of their face. It's a sign of malnutrition. Bad teeth due to the acid that constantly bathes their teeth when they engage in vomiting. They have sialoadenosis, or large parotid glands, you can see here and here, because of the daily vomiting. Lanugo hair. This is the fine, downy hair that occurs on face and all over the body, and it's in the body's effort to conserve energy and increase the core temperature. This is really the only sign that we have in anorexia that's specific. It's called Russell's sign, so it's these calluses on the back of the hand. However, as eating disorder professionals, we know that so many patients don't actually need to use their fingers in order to vomit. They can just do it by opening their mouth, so less of a sensitive test. Acrocyanosis, which our patient has, it's this discoloration of the digits, both the fingers and the toes, become a little bluish or purplish because the body is cold and it has decreased circulation. Other things, brittle nails, thinning hair, xerosis, or really dry skin, as you can see on this patient's forehead, and sometimes edema or swelling. And these are important things that we can tell our ED colleagues to sort of look for. So what do we do for our patient? She's dizzy, she has palpitations, she has a low blood pressure. Should we just assume she's dehydrated? She told you she had a stomach flu, give her IV fluids and rehydrate her? No, absolutely not. Why not? Well, because we don't treat asymptomatic hypotension and bradycardia in patients that are severely malnourished. We need to recognize that these vital signs are our baseline. She may have she may be complaining of dizziness and palpitations, but we need to look for other etiologies of this and realize that this is baseline. Why is that? Well, patients that restrict, they have lost cardiac mass. They may not be able to handle the fluid you're going to give them and go into heart failure. The purgers may get a lot of edema or swelling from their Pseudo Bartter syndrome and also precipitate heart failure. So we have to exercise caution in these patients, and really less is more. We need to recognize and recognize what they have and really understand that what they need is nutrition. So based on the physical exam findings, you think that this isn't related to the stomach flu, but she tells you she has no other symptoms and denies any behaviors. Are there any helpful screening questionnaires that we can use in the emergency room to help tease out whether a patient has an eating disorder or not? And there are. So this cough questionnaire was actually developed in England, and it was verified. There's 5 questions, and these are the 5 questions. Do you ever make yourself sick because you feel uncomfortably full? Do you worry you've lost control over how much you eat? Have you recently lost more than 1 stone in a 3-month period? That's 14 pounds. It was developed in England. Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? If you ask anyone that's the age between 10 and 40 years old, you count 1 point for every yes answer, and a score greater than 20, greater than or equal to 2 is likely anorexia nervosa or bulimia nervosa, with a sensitivity up to 100% and a specificity up to 94%. So it's an easy, quick test. We all know about the CAGE questionnaire for alcohol abuse, but we don't know much about this cough questionnaire, and it's a very easy tool that we can disseminate to our ER colleagues. So based on her, on this questionnaire, she scores 3. So you're a little more suspicious and decide to get an EKG and check electrolytes. And her EKG shows you that, for those of us medical, number 1, she has a very slow heart rate of 45, and number 2, her QT syndrome is a little bit prolonged. Oh, sorry, her QT is normal, although it can be prolonged in some of these cases. So what are the cardiac complications of an eating disorder? Well, arrhythmias are very, very common. The most common arrhythmia is sinus bradycardia, so a slow heart rate. Other things like junctional bradycardia, exertional tachycardia can exist, as well as QT prolongation. And for a long time in the medical world, we thought QT prolongation was inherent to malnutrition. So when your body weight got low, your QT prolonged. We now know that that's not the case. We need to look for meds and for electrolyte disturbances in these patients, because that's what's leading to QT prolongation and the risk of arrhythmias and then death. The scary thing is that all these arrhythmias can be asymptomatic in patients, so we have to get an EKG in our malnourished population. These patients also complain of chest pain, and the etiology of chest pain can be anything from electrolyte abnormalities to acid reflux to musculoskeletal, because the muscles between your ribs sort of hurt as you engage in vomiting. Mitral valve prolapse, which is you can hear as a murmur on physical exam. Anxiety can give chest pain, and really what the ER needs to learn about is pneumothorax and pneumomediastinum. What is that? Pneumothorax is air around the lungs. It's well described in the eating disorder literature. We don't know what the mechanism is. The hypotheses are that maybe the alveoli, which are the air exchange sacs in the lungs, have a weak structure, or there's decreased surfactant, which is the protein that bathes the lungs, or maybe they have a propensity for emphysema, so for these sort of bubbles to form and burst. We know that pneumothoraces occur with changes in intra-abdominal, intrathoracic pressure. What does that mean? Well, when a purger is actively vomiting, that changes both intra-abdominal and intrathoracic pressures. Restrictors, coughing, sneezing, any of these actions can trigger it. What does it look like? So this is on the right is a normal lung. On this side where the arrows are is a collapsed lung. So the lung is shriveled, and you can see this is air around the lung, very abnormal. So ER physicians need to know about this, and ER staff need to know about this so they can accurately diagnose and treat as needed. What is the treatment? We check EKGs, check electrolytes, chest x-ray, we get a thorough med list, and we don't treat asymptomatic conditions. Know when to hospitalize. Heart rate's less than 40, a prolonged QT, and rhythms other than sinus, and of course pneumothorax. So her labs trickle in, and they are literally all abnormal. All the electrolytes are abnormal. What's going on? So this is called Pseudo Bartter syndrome. When someone purges by vomiting, laxative abuse, or diuretic abuse, it leads to volume depletion, so dehydration, and loss of electrolytes, the salts in our blood. How does the body react to this? It increases the production of a hormone called aldosterone by the adrenal gland that makes us retain salt and water. And this is the action of aldosterone. So you're dehydrated, blood pressure falls, lots of hormones get activated. Finally, aldosterone signals the kidney to retain salt and water and increase your blood pressure. So what must we do for these patients? Number one, we need to recognize that their lab abnormalities are due to this hormonal overproduction. They have to stop purging, and then we need to give them some volume back and electrolytes. The key, though, is that we have to do this very slowly. We have to treat them like pediatric patients, slow IV fluids, 50 cc's an hour, because if not, every little bit of salt and water they're going to retain, get very edematous, which of course is terrifying for someone with body dysmorphia, but also medically they can go into congestive heart failure and then have complications and die. So it's important for the emergency room physicians to recognize this. Also, patients with abnormal electrolytes should be placed on telemetry or continuous heart monitoring. Hypokalemia or low potassium is so very common in purgers. It's also important to remember, and this is a great teaching point, that hypokalemia or low potassium in an otherwise healthy young woman is very highly suspicious of purging behaviors. If you see that in the emergency room, ask the cough questionnaire, and I bet you the majority of these patients are going to test positive. Hypoglycemia. Our patient was hypoglycemic. Why? Because the body stores glucose as glycogen in the liver, and when the glucose drops in the blood, the body signals hormones to break those glycogen bonds and release glucose in the blood. Well, when glycogen is depleted, when there's no more glycogen available, there's nothing that the body can release to combat hypoglycemia. So it's very important to test these patients. Check out glucose every time that you see them. If it's low, ask them to drink juice or a few ounces of a supplement. If they refuse, then you can go the IV route with IV D50 or get them some IV fluids with some dextrose in it. If you're going to do that, you need to be very careful because you might precipitate refeeding syndrome. What is refeeding syndrome? So refeeding syndrome is a deadly syndrome that occurs as the patients go from starvation to eating. So from a catabolic state of breakdown to an anabolic state of growth. These are the sort of risk factors for the refeeding syndrome. These are easy to Google. And our patient meets 2 criteria on the left and 1 on the right. So she's definitely at risk of refeeding syndrome. Anyone at risk of refeeding syndrome needs to undergo refeeding in a hospital, in a specialized center like ACUTE, in order to prevent mortality and morbidity. So these are the other more criteria of when to hospitalize a patient, especially that purges. Back to our patient, you talked to her about the fact that we suspect she has an eating disorder. She admits to it, but she's really scared of IV fluids, and you really win her trust by telling her you understand her pathophysiology. But now she tells you she has abdominal pain and is really constipated and would want a laxative. So these are the GI complications of malnutrition. We'll just go over a couple of them. The one that I want to draw your attention to is superior mesenteric artery syndrome, and I'll show you in a picture what that looks like. So this is a syndrome that occurs. This is the aorta. This is the SMA, or superior mesenteric artery, that innervates our gut. Right at the takeoff is a nice little fat pad that keeps these 2 arteries separated, and coming out at you, this circle is the duodenum, which is the first part of the intestine. As patients lose weight, they lose fat, and when they lose fat and when they lose this fat pad, the 2 arteries literally compress the duodenum. So then nothing is passing. Fluids, solids, those are difficult to pass, and the patient has a lot of abdominal pain. This is more of an anatomical view to see where the obstruction would be. Why do we worry about this? Because rarely, especially in the emergency room, they need to know this, it can cause acute gastric dilatation. Both SMA syndrome and gastroparesis, which is slowed gastric emptying that patients with malnutrition get, they can cause acute gastric dilatation. What does that look like? A very large stomach on x-ray that's unable to propel any food, and so fills up with any saliva, any food that goes in. What do we do for these patients when they complain of abdominal pain and you suspect this? Get an x-ray and consider getting a CAT scan of the abdomen, which will show you, again, SMA syndrome. That's a squish duodenum. These patients really need a surgical consult. They can't have anything to eat or drink by mouth and need to be admitted to the hospital. Constipation. Constipation is very, very common in these patients because of delayed transit through the colon. Abdominal x-rays can be helpful to determine stool burden, but really the ER should not be giving laxatives, especially stimulant laxative in these patients. They can have some osmotic laxatives like polyethylene glycol or glycerin, but otherwise it's best addressed either on the inpatient setting in a unit like acute or by their primary care physician. So important to hospitalize for acute gastric dilatation and complete SMA syndrome. Lastly, you call surgery, admit her to the hospital, and prior to going to the medicine floor, she tells you that she fell a few days ago and has excruciating back pain. What do you worry about? The number one thing to caution our ER colleagues about is osteoporosis. About a quarter of adolescents with anorexia and 38% of adults with anorexia have osteoporosis, or loss of bone mineral density. They can have low back pain or hip pain, and anytime they complain of this, they need a very thorough physical exam with maybe imaging, and certainly they need to be asked the questions of trauma, falls, fractures. What happened to our patient? Unfortunately, she had a vertebral compression fracture, so she fractured her vertebrae. These patients with osteoporosis have a 60% risk of lifetime risk of fractures. So we need to medically manage her pain, give her a diagnosis by obtaining a DEXA scan to determine the severity of bone loss, and then talk about treatment strategies with her. So again, when to hospitalize, these are more, we keep adding criteria to when these patients need to be hospitalized. And so this is sort of an overview of some of the medical complications that the ER physicians need to be aware of and need to be on the lookout for when patients present to them with a suspicion of an eating disorder. And I'm going to turn it over to Dr. Lashen, who will guide us through the psych emergencies of this illness.
Great. Thanks, Dr. Mascolo. I'm Dr. Gillian Lashen. I'm the clinical psychologist here on ACUTE. And I'm going to talk with you a little bit about some of the kind of crisis issues that can show up in the emergency room, namely patients that might be refusing treatment and how to go about assessing criteria for involuntary treatment. So just to quickly review the objectives here, we're going to talk about what involuntary treatment is, review some of the legal statutes and what grave disability is, since that's a big part of this, identify who meets criteria for involuntary treatment, and then discuss the benefits and challenges of involuntary treatment. So when we're talking about involuntary treatment, we're typically talking about folks with life-threatening anorexia. And Dr. Mascolo did a great job of emphasizing just how dangerous severe anorexia or other eating disorders can be. We know that there's a high mortality rate, 5 to 10 times higher than age and sex matched subjects, and that it's the psychiatric illness with the highest mortality rate. We also know that folks with severe anorexia or other eating disorders can be pretty ambivalent toward treatment and oftentimes might be resistant or outright refusing treatment. There can be impaired judgment and information processing when people are very ill from their eating disorder. On admission, patients treated involuntarily tend to have lower full-scale IQ scores than those treated voluntarily. It also can be difficult for patients to perspective take when they're very ill. Starvation can impact their ability to set shift. It can cause weak central coherence, and this can create difficulty with perspective taking and insight, leading to irrational decision making, perhaps. And we also know that nearly all the medical complications of anorexia can resolve with nutrition. And so when we see patients refusing care, they're often refusing life-saving care, and that can be really dangerous. The majority of patients here on acute fall into this category. The average BMI of patients we see tends to be around 13. And also patients in the ER oftentimes are going to be very ill with low BMIs because they're there to have their medical complications treated. And we know that folks that have more severe eating disorders tend to have more medical complications. So let's talk about what involuntary treatment is. There's a lot of terms that can be used to refer to involuntary treatment, and I'll sort of use them interchangeably. Commitment, compulsory treatment, detention, mandated treatment, coercion or coerced treatment. Those are all terms that can be used to describe essentially involuntary treatment. So when a patient's being treated involuntarily, they're being detained and treated against their will, so they can't leave treatment voluntarily during that time. They've been deemed to be a risk to themselves, others, or again, gravely disabled, and that's an important term we'll come back to. Typically, if someone's being treated involuntarily, there's some sort of legal order or legal court involved. And while involuntary treatment can include the use of physical restraint, force feeding, involuntary medication, it does not always, and in fact, it often does not include those things. And involuntary treatment typically is instated following a voluntary admission, and this is often sort of a misconception. People think that folks that are treated involuntarily are brought in that way, but oftentimes folks come in, they're feeling really lousy, they want to get help, and then they decide at some point they want to leave. Maybe, they get fluids in the ER and they decide, oh, I'm feeling better, I'm going to go ahead and go, and at that point, sometimes involuntary treatment will come about, again, after someone's voluntarily come in for care. It's important to note that involuntary treatment is not medical guardianship. So medical guardianship can be useful in assisting with decisions regarding medical treatments such as tube feeding, but it doesn't extend to psychiatric care. So a medical guardian cannot initiate commitment to mental health institution. And it's also really important to note at this point that we always are going to attempt to engage patients voluntarily first. We always want to work on a voluntary basis if at all possible, so we'll make multiple attempts to engage them voluntarily before we start to consider involuntary treatment. So involuntarily treated patients, as compared with patients that are treated voluntarily and have anorexia, tend to have more severe symptoms of anorexia. They tend to have been ill for a longer duration of time. They might have had more previous hospitalizations. They might have more psychiatric comorbidity or more severe comorbidity. They tend to have higher levels of depression and a greater history of self-harm. So it's important to ask, how effective is involuntary treatment? Well, what we know is that weight at discharge is similar for voluntary and involuntary patients alike. So that means that patients that are treated involuntarily tend to weight restore as successfully as those that are treated voluntarily. And so for this reason, short-term treatment of voluntary and involuntary patients is comparably effective. However, it is important to note that it oftentimes can take longer for involuntary patients to weight restore, which is likely reflective of them admitting at a lower body weight. We know that initially resistant patients can change their attitude over time. So it can be effective in the sense that folks that might have initially refused treatment or been resistant to it as a result of their illness or impaired judgment can come around over time. So it's effective in that sense. And some patients, though certainly not all, can be grateful in hindsight. So maybe it takes longer for those folks to come around, but they can look back and say, I was glad that you all hung on to me and helped me get better. So is involuntary treatment legal? This is an important question. And the answer is yes. And it's also important to know that all states are different and that it's important in your state to know what the statutes are that govern civil commitment, because they can be dramatically different. So I'm going to talk about here in Colorado, where the mental health laws are quite favorable towards treating patients with eating disorders involuntarily, assuming they meet criteria. And while we certainly, of course, respect autonomy and civil liberties, we do have a legal basis for imposing involuntary treatment for those that are gravely disabled as a result of their eating disorder. So let's talk about grave disability. So here in Colorado, grave disability is essentially defined by someone who has some type of serious physical compromise, like significant weight loss, dehydration, electrolyte imbalances, all the things Dr. Mascolo just articulated for us. And those serious medical issues are the result of impaired judgment regarding their nutritional needs. So if they have physical compromise and it's the result of their impaired judgment regarding their nutritional needs and they're refusing treatment, then we can make a case that they're gravely disabled as a result of their eating disorder and pursue what's called a 72-hour mental health hold. So the mental health hold, as the name implies, 72 hours, it allows us to keep the patient so that they cannot leave the facility, and this can only be done here in Colorado at facilities that are 2765 facilities. That means facilities that are licensed to do involuntary treatment. And in that 72 hours, we're going to evaluate and treat the patient. There are 3 possible outcomes. The patient can be released, and that can either happen at the end of the 72-hour period or anytime within. The patient may be referred for further treatment on a voluntary basis, which is always an optimal outcome of a mental health hold, that the patient decides to sign involuntarily and continue with treatment. Or the patient can be certified for ongoing involuntary treatment. And if that's the case, the third outcome, certification, then the first step would be what's called a short-term certification, which can stay in place for up to 90 days. And if it's determined that the patient needs ongoing involuntary treatment, then you can go before a court and ask for an extension, which would be another 90 days. A long-term certification can come after that if granted by a court, which is 180 days, and so on and so forth. It's important to note, though, that at each extension request, you have to go before a court and demonstrate that the patient continues to meet criteria for involuntary treatment. Again, I want to emphasize that using a mental health hold or any type of involuntary treatment is always going to be a last resort, and only when a patient has life-threatening eating disorder and can't sort of appreciate the severity of their condition. So another important question to ask is involuntary treatment ethical? And this is a complicated question to answer. And for the purpose of this presentation, I won't get too much into the literature and some of the different viewpoints on this, though there are some great articles in the references that I have that can further explore this. But really the key issue that often underpins this debate is how to balance the respect for a patient's individual autonomy with our responsibility as providers to save a life or keep our patients safe. So the literature does indicate that there's general agreement that involuntary treatment should be used only as a last resort to save a patient's life. So there's strong consensus that involuntary treatment should and can be used in life-threatening anorexia. There is less consensus, however, around the use of involuntary measures for the treatment of anorexia in the absence of an immediate risk to life. So let's talk about when we should consider involuntary treatment. So if a patient is, let's say, in the emergency room and refusing either any care or, again, wanting to leave after receiving just sort of basic life-saving care rather than admitting to the hospital to receive ongoing care, that might be a point where we would consider involuntary treatment. Here on ACUTE, we'll sometimes see folks be willing to admit and get medical care and get medically stabilized here on the unit, but then they're refusing to go on to care after ACUTE or arguing for an inappropriate level of care, like perhaps they want to step down to an intensive outpatient program, which generally isn't the right next step for our folks given the severity of their eating disorder. So at that point in time, we also might consider involuntary treatment. Suicidality, so being a danger to oneself or anyone else, electrolyte imbalances, cardiac arrhythmias, BMI lower than 13, given that that puts someone at greater risk for refeeding syndrome. Those are other indicators that we might want to consider involuntary treatment. It is important to consider stages of change. So involuntary treatment may benefit a patient with anorexia who's in the first state of change or no change, and their life is threatened. However, involuntary remission in the other states of change, contemplation and action, may prove harmful for the patient's engagement in treatment and their therapeutic alliance. So that's something to consider. And then timing can be a matter of debate. There really isn't consensus on whether or not involuntary treatment should be utilized early in the course of illness to prevent deterioration. So some argue that early intervention can shorten illness duration and that improves prognosis. And they sort of make the analogy to schizophrenia, where the duration of untreated psychosis is an important prognostic factor. However, when we're considering stages of change and the idea that most people really support involuntary treatment in the setting of life-threatening anorexia, it's hard to make a case that we should be doing it for folks that are earlier on in their illness. So when we're assessing for involuntary treatment, there are multiple sources of information that are important to consider. In addition to all the information that hopefully our patient is sharing with us, we also want to get family collateral. Oftentimes, folks with anorexia, particularly severe anorexia, might not be the most reliable reporters, either because they sort of lack the insight to be able to really describe what's going on for them. They might be minimizing their disorder. So family collateral can help us get more robust information. We want to assess their level of psychosocial functioning. So are they able to hold down their job? Are they going to school? Are they parenting? Are they being a partner? How are they functioning in day-to-day life and in their roles? What level of physical compromise do they have? So assessing for all the complications that Dr. Mascolo articulated, and really looking at how serious is their medical state. What's their level of cognitive functioning? Are they able to really appreciate what's going on for them and cognitively track? We know that starvation can impact cognition, like we talked about briefly. We want to assess the patient's level of insight into their illness. This is important when we're talking about one's ability to meet their essential need of nutrition. If they can't sort of appreciate the severity of their condition, we're going to be more concerned about that, and that plays into the grave disability piece. We want to learn more about their treatment history. Have they been to treatment before? And history of medical hospitalizations, which helps us have a better sense of just how severe their medical condition is. And then we're always considering ethical principles of fidelity and respect for people's rights and dignity. So the second part of assessing for involuntary treatment is assessing who meets criteria. And so we tend to think that folks under age 30 are important to consider for involuntary treatment because we know that they're still cognitively developing. If a patient has limited or no prior treatment, we're definitely going to consider them for involuntary treatment, assuming they meet criteria for grave disability, because they haven't had the opportunity to benefit from treatment. And we don't know, we can't say definitively that it won't help them if they haven't ever really tried. If a patient has a history of leaving treatment AMA against medical advice, we're also going to want to consider for involuntary, assuming they meet all other criteria, again, because they very well may benefit, they just really haven't had that experience before. And we know that leaving treatment prematurely doesn't produce as good of outcomes. If a patient has limited or no history of full weight restoration, we'll consider involuntary treatment. If they have poor insight, they're going to be more likely to be considered for involuntary treatment, again, because they're going to be at greater risk of not being able to meet their needs and stay safe. If they have impaired functioning, that really speaks to the severity of their eating disorder, so we're certainly going to consider involuntary treatment. And if they have significant medical complications as a result of their eating disorder, or let's say they're kind of more or less stable at the moment, but they're at very high risk for physical compromise should they be without a high level of supervision and support, then we would consider involuntary treatment as well. And it's important to note that no one of these criteria in isolation is sufficient for mandating treatment, but they're all important considerations. So briefly, I want to touch on the challenges associated with involuntary treatment. Because as you might imagine, there certainly are some significant ones. So again, coming back to this concern for patient autonomy, this is where many clinicians struggle with the decision to mandate treatment. Also, Rathner, in a paper entitled A Plea Against Compulsory Treatment of Anorexic Patients that he put forth in 1998, argued that voluntary treatment of eating disorders already contains many elements that are perceived as coercive, and so formal involuntary treatment would be one coercion too many. Michael Strober actually argues against involuntary admission when a patient is contemplating the need for change and recovery because it can prove harmful for the patient's engagement in treatment. So again, that idea of assessing readiness to change is important. As we might imagine, involuntary treatment can rupture the therapeutic alliance and sometimes make the patient want to abandon treatment altogether. And if you think about that, there's no such thing as involuntary therapy. So we can't make these patients engage therapeutically, and that's important to consider when we're assessing for involuntary treatment. And then resistance and control. So we know that folks with anorexia, control is an important factor to them. And so involuntary treatment can sometimes provoke increased resistance to treatment because patients feel like they're not in control of their lives. And then just logistically, insurance and access to care can sometimes present challenges when we might think someone meets criteria for involuntary treatment, but perhaps they don't have the insurance coverage, or there isn't a facility that can do involuntary treatment in their area. So what's the patient's perspective? There's consensus that from surveys that study the attitudes of patients with anorexia, that involuntary treatment is appropriate when the risk of mortality is high. So there were 2 studies that surveyed attitudes of patients and mothers of patients diagnosed with anorexia, and found that the majority of those interviewed deemed the use of involuntary treatment as appropriate when the risk of mortality was high. So restriction of choice and involuntary treatment overall can be experienced as less negative and even sometimes as good care if it's conducted within a trusting and supportive relationship environment, and patients really emphasize that. So a person-centered environment can help the patient feel honored as an individual person. It can empathize, it has warmth and congruence, and this is really important to the patient's experience. So I want to briefly touch on mortality in involuntarily treated patients. So a study that was published in 1999 looked at admitted patients with anorexia at Maudsley Hospital by Ramsey and others, and they had a striking finding that at follow-up, there were significantly more deaths among the patients that had been treated involuntarily than those that had been treated voluntarily. And so they concluded in this initial study that there was short-term benefit to involuntary treatment, but increased mortality at 5-year follow-up. So then Ward and others, many of whom were researchers involved in the Ramsey study from '99, in 2015, they followed up with that same group of patients after another 10 years, so now a total of 15 years out from treatment. And although overall mortality in the involuntarily treated group did remain higher at follow-up, the difference between the groups had reduced over time so that no significant differences were found overall in the 2 decades after admission. So the findings of this follow-up study don't support the initial hypothesis that compulsory treatment or involuntary treatment itself has effect on longer-term mortality. And the findings of the follow-up study were in line with other studies that have shown that mortality rate decreases as the follow-up period increases. It was also consistent with the finding that the risk of premature death among patients with chronic anorexia peaks within the first 10 years of follow-up. So just briefly in summary, patients and providers alike generally agree that involuntary treatment is indicated and appropriate when someone has a life-threatening eating disorder. Involuntary treatment produces short-term benefits, though the longer-term outcomes lack some consensus. There are many challenges associated with involuntary treatment, and trusting and supportive relationships between patients and treatment providers are essential.
Thank you so much, Dr. Lashen. Can everyone hear? Okay. I just wanted to touch base on one thing. So we've gone over the medical complications and sort of the psychiatric complications. What can you do if your facility does not have expertise in patients with eating disorders? I mean, if you've deemed that either medically or psychiatrically they need to be seen in a hospital such as ACUTE that can take care of all their complications, and your facility isn't equipped to do so. Well, I wanted to just touch base on the fact that ACUTE has, sorry, Dr. Lash, perfect, thank you. ACUTE has a partnership with Angel MedFlight. They are an air ambulance company, and they literally have the ability to fly patients from any hospital or emergency room across the country to ACUTE. We've developed protocols with them to make sure that our patients safely take off from their facility and arrive at ACUTE. Things like glucose checks and IV fluids and what the vital signs should look like, all the way down to a turning schedule for when they're in their bed so they don't develop decubitus ulcers. And so it's really been crucial in getting some of these very ill patients from other facilities across the country to acute to get the proper care that they need. And once you call our intake line, it's actually very easy to for our intake specialist to get a hold of Angel Med Flight. They arrange the transport, they pay for the transport, and then fight the insurance on the back end. And so with that, we'll open it up to questions.
Thank you so much, ladies, for your very informative and helpful presentation. We really appreciate your time. And just as a reminder to our attendees who are still live with us, if you look in the chat box of your control panel, you will see that there is a link to our CE evaluation form. If you can please click on the link, it will take you directly to the form. You can quickly fill it out and submit it, and then that will allow us to process the information for your CE credit. And so we are transitioning into the Q&A portion of our presentation. Just as a reminder, if you have a question that you would like to submit, please feel free to type it directly into the question pane of your control panel, and we will be going through those now. So we do have one question from an attendee. It's a little bit long, so I'm going to try to break it up into little parts. So first, our attendee writes, I am a past patient and practicing professional. What would be your recommendations for someone who has severe anorexia yet has no past success with behavioral change in inpatient or residential treatment?
I think Dr. Lashen, that one's for you.
Yeah, so without knowing much more, it's difficult to say. So I guess I would just sort of come back to some of these factors we discussed briefly in the presentation, that often, age plays a role, that again, folks that are under 30, even if they haven't had success in treatment before, we tend to encourage them to continue trying, because we know that cognitively the brain is still developing, and there's still the possibility that sort of what they're learning and working on treatment can take and can make a change. And that's not to say that folks beyond 30 can't change and can't benefit from treatment, but that's sometimes something that we'll look at. And oftentimes folks maybe are going back to the same treatment center that they've been to before, and so sometimes a change, just getting a different perspective, working with a different treatment team can be helpful. But certainly we know that eating disorders are powerful, and oftentimes it takes not just one go at treatment, but sometimes multiple goes at treatment. And I tend to conceptualize that as sort of, we do the work we can do when we're in treatment, and sometimes we resolve some emotional pain, and then our eating disorder comes back because we didn't quite resolve all of the emotional pain. And so then we come back into treatment to continue to work on our unresolved pain, because that tends to be what keeps our eating disorder going.
Thank you, Dr. Lashen. And this is kind of the second part of this question. Our attendee writes, how would you suggest that she continue to be treated as an outpatient, considering the fact that she is medically compromised yet cannot be committed at this time and desires to continue school? She also said, I do understand medical risks, but will not refuse treatment unless I am mandated to report to emergency services. How can I best support this patient in her journey toward health?
I'm sorry, is it a provider or a patient that's asking the question?
She's a provider. She is a therapist. I'm sorry.
I see.
Yeah.
Okay, so that's helpful to understand. It's really tricky in the outpatient setting, I would imagine, though, as an inpatient provider, it's hard for me to speak definitively on this, but I would imagine it's really difficult as an outpatient provider to get a patient to go into treatment, because you can't make them go involuntarily most of the time. Again, it's state by state dependent. But I think, like we talked about in our last webinar, that really persistence is key, just continuing to raise the issue of a higher level of care and explore resistance and offer support, and make sure that patient knows that that's really your recommendation. And I think, some outpatient providers will at some point say, gosh, I just really can't work with you in this level of care anymore. You need a higher level of care, and I'll be here when you get back, but it's unethical or unsafe for us to continue in this relationship, given that it sounds like she's saying this patient has medical complications. So I think persistence is key.
Thank you so much. I appreciate your insight on that. Another question here, how different might eating disorder behaviors vary from culture to culture? Do they all look the same?
I don't know, Dr. Mascolo, you might have some ideas. I'll just mention quickly that I think the answer is yes, they may differ from culture to culture, and it's important to be culturally sensitive. What might actually look like an eating disorder behavior in one culture might be actually quite appropriate for that culture, and so I think it's important. Context is always important. So taking in any patient's sort of history, cultural context, and background is really an important consideration.
I agree. I mean, medically they have the same consequences, but it certainly looks differently from culture to culture. Mm-hmm.
Right, like the behaviors, yeah.
Okay.
Thank you. Another attendee is asking, how would you change admission requirements for a pediatric patient?
I'm actually unable to speak to that. I'm an internist, and while a lot of our patients have vital signs that are more similar to the pediatric population because they are at such low body weight, I would sort of be speaking beyond my expertise to talk about kids. I am not allowed to take care of them.
Thank you, Dr. Mascolo. We have another question from one of our attendees wondering if I think she's a dietitian and asking if in an outpatient setting, if I'm screening for basic physical symptoms, what are some main things I should be aware of that might cause me to consider referring a patient to the ER?
Medical symptoms?
I believe so, yeah.
Yeah, so again, they can be very vague. Unfortunately, it's things like dizziness, weakness, fatigue, palpitations, occasional chest pain. Because of the strong sort of gut-brain axis, there's a lot of GI complaints, constipation, pain with eating. All those things should certainly prompt further questioning and further evaluation, depending on the severity of symptoms, and they may need to be evaluated at the emergency department, But they're very, very nonspecific, unfortunately.
Great, thank you. I think this is another follow-up question to that, but do you think there's anything that outpatient providers such as therapists and dietitians could do differently in their initial screening to help assess, those patients that are more severe and needing more acute care?
No, I mean, I think obtaining vital signs as objective sort of evidence. I think screening labs, again, the restrictors are going to have completely normal labs, but I think getting something like a chemistry panel with magnesium and phosphorus, liver function panel, a complete blood count, a TSH or a thyroid function test, and a baseline EKG, those are helpful. I think a finger stick blood glucose at every evaluation is important, especially for the severely malnourished patients. And of course, you guys are going to have to teach the physicians about eating disorders because there's very little known by physicians about these disorders and what the complications are.
Yes, that kind of rolls into the next question we had, which is how can primary care physicians better screen for acute eating disorders?
So I think number one, asking this cough questionnaire of every patient that comes in that's age 10 to 40. I think always obtaining a height and weight at your evaluations and figuring out IBW and BMIs. I think sometimes, it's just easier to see that black on white. If someone has a BMI less than 15, then, there's definitely something going on. But, BMIs of less than 18 are certainly abnormal as well. And again, I think screening labs to make sure that you're catching the hypokalemia and the purgers, any other lab abnormality.
Great, thank you. Another question here, do you know of any facilities like ACUTE that can handle patients less than 16 years of age?
You know, I don't. I mean, there's some pediatric hospitals. I think CHOPS is an excellent facility, but I don't know of other centers that do what we do, that take our severity for pediatrics. I'm sorry.
Okay, thank you. I think that wraps up all the questions we have. I'll just put this out as the last call. If any other questions that you would like to submit, if you're still watching with us, please go ahead and put those into the question pane of your control panel before we wrap up this evening. And just a reminder that you will need to submit the evaluation form in order to receive your CE credit. There is a link that will take you directly to that evaluation form in the chat box of the control panel as well. And I guess just to conclude, if ladies, you could maybe just review the information about ACUTE and the facility and where individuals can find out more information if interested.
Yeah, absolutely. So we are located in Denver. We're located in a level 1 trauma hospital in the heart of Denver. We are a 16-bed facility that takes patients that are 17 and up of all genders. All the rooms are individualized with individual bathrooms. Our patients are seen 24 hours a day, are with a CNA or a certified nursing assistant with a certified nursing assistant 24 hours a day. They receive individualized psychotherapy, supportive psychotherapy 5 days a week by doctors such as Dr. Lashen. They see a registered dietitian 5 days a week. They're evaluated daily by an internal medicine physician. Our nurses are trained in eating disorders and dedicated to eating disorders. We have a team of social workers that works on disposition starting from essentially day one of their hospitalization. We have a chaplain available to these patients as needed. And everything is one-to-one, so they eat by themselves. We don't have group therapy, and we're able to medically stabilize them over a period of about 2 to 3 weeks. That's our average length of stay. Last summer, we had a patient that had a BMI of 6.2, so she stayed for much longer, but our average length is about 2 to 3 weeks. And then they transition to inpatient or residential facilities all over the country. So that they can continue on their recovery journey.
Wonderful. Thank you so much. And do you have, again, the contact info or, oh, I see it's all on this slide. Sorry.
Yeah, so the thing that I would say is that our intake specialists are phenomenal, and if a patient is not the right fit for us, they absolutely can help you troubleshoot where the patient could go. If the patient needs an air ambulance, you just have to take our in-call line, our intake line, and then they're able to handle everything else.
Wonderful. Thank you so much. And yes, all that information is on the slide you have up. And that concludes our webinar presentation for this evening. So thank you so much again, Dr. Mascolo, Dr. Lashen, for your time and for sharing your expertise with all of us. We just so appreciate you being here.
Thank you. Great. Well, thank you so much for having us.
Thank you. And again, to all our attendees who took the time to join us this evening, we thank you so much for your time. You're also welcome to check out eatingdisorderhope.com for additional resources. We also have our upcoming webinars schedule on the website as well. We will also be sending out a link after this presentation with the recording of the full replay in case you'd like to listen to it again. And if you haven't had the chance to do so, just a reminder to please fill out your evaluation form if you would like to receive a CE credit for tonight's presentation. So on behalf of Eating Disorder Hope and the Acute Center for Eating Disorders and our presenters, thank you so much and have a wonderful evening.
Thank you.